Well, thank you so very much for the invitation to be here today. I'm very excited to come and talk a little bit about some of the work that I've been able to do at Sacred Heart Medical Center out in Spokane, Washington. We're talking about solid consolidation and high standard standardization. This is my disclosure slide. And then here are the learning objectives for today's talk. So hopefully we'll cover each of these. So as a bit of background, I just want to take a second to talk a little bit about Providence Healthcare. This is a large network of community hospitals and laboratories. It's very large. It covers 7 different states across 3 divisions of these different sort of sub-regions. I'm posted out in eastern Washington, Montana, and you can see both the footprint and each of those is an individual laboratory. So Providence is comprised of 51 hospital laboratories, 30 ambulatory labs, and a lot of point-of-care offices, but predominantly we are an acute inpatient hospital laboratory, and that is the bulk of the work we are doing in the laboratory space and the kind of testing that we do. So it's a very sort of a different scenario, I think, to what I experienced today at the University of Washington, where of all these different statistics, there's only one PhD clinical microbiologist, and that's me. There was a brief golden moment where there was 2 of us, but that went away very quickly. But the big kind of takeaway, I think, for Providence is that, yeah, we're really just a network trying to do our best to serve our patients where we are at with the laboratory services that we have. And that leads us to this first part, which was already sort of mentioned, but the creation of a regional core microbiology laboratory, how we did this and why. So definitely this is a topic of very intense conversation around a lot of laboratories, and I know that this is close to home because of some consolidation and laboratory changes that will be happening here locally. But during reviews of the kind of consolidations and core lab formations that have occurred, definitely financial pressures are probably one of the greatest reasons why laboratories tend to undergo this consolidation. And it makes a lot of sense. Across all services, we are seeing decreasing reimbursement in the laboratory space, both in general trends and also specific legislation has resulted in some of those changes. When you have a large consolidated laboratory, you get those economies of scale and labor efficiencies. And then there's just ongoing workforce challenges, both with general laboratory staffing and then microbiology expertise in particular. To just kind of paint the picture and remind, maybe this audience already knows about this current status of the medical laboratory scientist and medical laboratory technician staffing, comparing registered nurses in the United States compared to the MLS-MLT population. You see those who are actively involved in the professions, the projected vacancies, and so while compared to nursing, MLS and MLTs have a relatively similar vacancy rate, when you compare that to the number of individuals graduating new programs, there's a lot fewer graduates willing or able, I should say, to take those vacancies when they occur. So if you're going to consolidate a microbiology laboratory, there's some different models and different approaches that need to be accounted for. First, is this going to involve a commercial laboratory or development of an in-house lab? So are you going to use an outsourcing to a commercial reference lab, LabCorp, Quest, others? Or are you going to use the existing instrumentation and building up infrastructure that already exists in your own network? Are you going to be testing predominantly acute, like inpatient or ambulatory outpatient? Do you have an urban or rural mix? What are test menu modifications you have to undergo? How is reimbursement going to be handled? And then some other questions are, what about the kind of sort of traditional reference lab model of centralized testing with specimens all flowing to one location? Or will there be some sort of rapid response or satellite laboratory capacity for those gram stains, blood cultures? And then what staffing and courier capacities exist to support each of those? So there's a lot to think about. So what was it like for us consolidating our regional micro labs? I like to say it's like eating a whale. I don't know if anyone else grew up with the Shel Silverstein poems, but this is a poem from the book Where the Sidewalk Ends about, it's called Melinda May. Have you heard of tiny Melinda May who ate a monstrous whale? She thought she could, she said she would, so she started right at the tail. And everyone said, you're much too small, and that didn't bother Melinda at all. And she took little bites and she chewed away slow, just like a good girl should. And in 89 years, she ate that whale because she said she would. So when we went through the process of consolidation, we didn't have that length of time. But why did we do it? Because, like eating a whale, it was the best option available at the time. We had to do it very carefully. We had to research the best way to do it. We'd made a bit of a mess, and we didn't want to do that, but it was despite our best efforts, and we couldn't do it alone. but we really did it one piece at a time. So today, I'm going to talk about some of those pieces. So by and large, I think the more interesting to this audience steps of this process are shown here, and this is sort of the map for this first part of the talk. Some other aspects of consolidation that relate more to a formal executive pro forma that needed to be developed, human resources, technological investigations and requests that need to be made. I'm not really going to go into too much detail. But we're going to start first at the top with the conception phase. Why do we think we want to do this? So this is a little bit about my home hospital, Sacred Heart Medical Center in Spokane, Washington. So this is the largest hospital and laboratory in the Washington and Montana region, and actually in that very large Providence network, it's actually the largest hospital and laboratory in all of that space. It's a 648-bed hospital, and we have another sister hospital just up the road in urban Spokane. So what about the laboratory? Well, we certainly had the largest physical space. We had a dedicated AFB and fungal laboratory space, a MALDI-TOF, and labor pool, just because of the urban nature of where we were located. And also there's an in-house school of medical laboratory science that we recruit a lot of folks from. So you can see some of those features here in our very awesome laboratory. So if it makes so much sense, if we had the laboratory, why did it take so long? And how did we finalize this core lab location? Well, as of 2020, the only Providence region that did not have a core microbiology centralized testing location was Washington, Montana. And that's largely because of the extensive geography and distance between these sites. So this yellow star is where we are located in eastern Washington, with rural hospitals in northern Stevens County, some southeast and Montana locations, and then over here on western Washington. And in between all of those are these very extensive distances and mountain ranges. So it made a lot of sense. Trying to get things to that central place is very, very challenging. And one thing that kind of forced our hand and made us start to think about this was the need to, in 2021, centralized high-volume pre-procedural COVID-19 PCR testing. This is so that patients could, undergo their surgeries in a safe amount of time when they would not be COVID positive. So we were able to acquire some Abbott Alinity M instruments. We got some nice coverage in our local newspaper to kind of talking about that. And because of this, we established a region-wide daily specimen delivery to Sacred Heart Medical Center. So we knew the location was there, and we knew that the courier routes existed. So next we needed to do some proof of concept testing. So the key features that really underlie all of what we do for our regional microcore lab were twofold. First, that our spoke sites needed to retain that critical on-site microbiology testing capability. That means the blood culture instruments. We know that ideally those collections get into the instruments within 4 to 6 hours for ideal recovery time. They needed to keep those rapid molecular platforms, gram staining reading capacity, and culture plating. So the other big component is that our core lab model relies on pre-plated and incubated cultures set up at the satellite sites that are then incubated in warmed incubated totes. And why did we do it this way? There was a survey in 2012 of 18 different pre-consolidated laboratories. And interestingly, in that survey, they talked about what's the best technique for managing specimens. Specimens with low levels of organism that potentially may not recover in culture, what's the best method for doing that? And at the time, at least according to this survey, there really was not a template of best practice. So the risk of long distance transportation of clinical samples resulting in non-viable, non-culturable organisms was a real concern. And there wasn't a established, this is what you must do. So we really wanted to go with this pre-plated method. And we knew that the use of warmed incubation totes had been used in a smaller scale elsewhere. And we also knew that we needed to scale up and using commercially available products. There are certainly medical device manufacturers who make versions of some of the materials I'll be showing you, but none that we could buy at scale. So the very first thing in this proof of concept step was understanding can we design and demonstrate the performance of a commercially available warmer and an insulated tote. And you notice I'm saying the word tote because they're actually just coolers, but I don't want to say coolers because they're actually kept toasty warm. So these totes, the experimental question we're really trying to get at here is, does a temporary incubation in one of these warm totes impact acceptable clinical culture performance? So we needed to test the length of transit time, how long it would ideally and maybe not so ideally take to transport across this geographic distance, ambient temperature of room temperature, but hey, we get very cold winter months. If it gets a little bit cold in the back of these courier vans, what does that look like? Then we had to develop and decide numbers and design of the warmers that would be doing the actual incubation. So to test this, we used clinical samples that we plated in duplicate, one that spent 7 hours inside of a tote and another set that went directly into the in-lab incubator. After 7 hours, they were combined back into the in-lab incubator the way they would in the core lab model, incubated and then evaluated by the bench. And we're very happy to see very good performance. So we were very strict in the exact culture agreement method where every organism in the same exact quantities were recovered. And testing close to 200 different samples across all of our different culture types, we saw 98% or close to 98% exact agreement. And really important to me is that even when we look at subdivision of only the positive cultures, room temperature, or colder temperatures, where we actually took these into our walk-in refrigerator for the length of time, we didn't really have, with only one exception, did we ever have a culture that was incubated temporarily in the tote that did not recover a single organism that was in very, very low volumes in the direct in-lab incubators. We did see a few incidental rare contaminants, but this helped support the idea that we would not necessarily inherently be losing or not recovering important organisms by that temporary tote incubation. So we knew the location. We knew that at least in an in-lab, in vitro model, these totes would work. The next thing we needed to do was evaluate what is the potential impact to our actual test results. So the highest concern among clinicians and clinical providers to this approach was the delay to culture results. So to really sort of address this and kind of understand the scope of the possible impact, we needed to model essentially what the proportion of cultures from the spoke lab, both in terms of the total percentage and the time of day of arrival, currently, under the current status quo, have their preliminary results reported the next day. We were really focusing on that first preliminary charted result as our metric. So I'll uncover this gray box in a moment, but what you're looking at is essentially looking at the proportion of laboratory specimens that arrive to the microbiology lab over the course of 24 hours. So this is 0 to 23 hours, and the percentage that arrive early in the morning, later in the morning, afternoon, and at nighttime. And then across the other axis, we're looking at the length of incubation, the number of hours in a day until that culture has reached the appropriate length of time for evaluation. So very colorful, but what really the takeaway here is that if you imagine cultures that are arriving into the laboratory just after midnight, before 1 a.m., they're going to be struck out and plated, assuming that they can be plated at that time. They're going to incubate all that next day, but they're really not going to reach the time when they could have any sort of preliminary workup performed. They're going to wait in that incubator really until the following day, on the day shift, when they can first be taken out of the incubator and read and reported by the bench. And we see, looking at this type of analysis, that for specimens arriving between the hours of midnight and around 1 p.m., well, these cultures will certainly by that day of first reading time be fully able to have some kind of preliminary result entered. But as soon as we hit 2 in the afternoon all the way to the end of the night, it's going to be very hit or miss as to whether or not there's even going to be a culture result entered into the patient's chart. So essentially what this helped us demonstrate is that under current status quo, where the hospital has its own microbiology laboratory in the basement, really only about half or less than half of those cultures are going to be ready to be worked up on that first possible day of culture, and everything else is going to wait one additional day. And we compare that to modeling out the ideal state of a core laboratory when we have a day shift and an evening shift able to read and report culture results. And the difference is really stark. So regardless of what time of day those samples are arriving into a spoke laboratory, and even taking into account this period of transportation when they're in those incubated totes moving toward the core laboratory, because our day and evening shift timing, every single one of those cultures is going to have an opportunity to be read and have a result entered into the patient chart ready for the providers to see the very next morning. So comparing again these two approaches side by side, which as a caveat, is very idealized. We know that not every culture is touched the second it reaches 18 hours or the moment that those techs come in for the day shift at 5 or 6 in the morning. But this really did help us understand, hey, this actually is going to not only not inherently result in a degradation of service in terms of timing, but also there's ample opportunities for improvement over the status quo. I'm also kind of pointing out here that given the length of time that many of our cultures need susceptibility testing incubation, there's actually some additional opportunity where cultures that are read and have susceptibility testing set up first thing in that first morning, they might actually have susceptibility results that are ready on that same day, ready for the next day. I'm not showing it, but this kind of modeling also helped us decide a few other things like the ideal time for dropping off at our core laboratory, and even whether or not it'd be worthwhile from a reporting standpoint to have 2 different courier runs. And it really not only wasn't, but just adding 1 additional courier run for this big geographic region would have added an additional $1 million to the annual cost of this core laboratory, undoing any financial gains that we'd achieved. So one other area of clinical impact, of course we are really focused on and worried about our patients, but this microbiology lab consolidation, ours or anybody's, can have significant impacts to clinical education and training programs. So in the clinical education space, there was a survey in 2018 of 776 IDSA members, specifically about microlab consolidation. And one of the questions of that survey was, is an on-site microbiology laboratory important for education and teaching? And 3/4, 75% of the respondents said it was very important. And then when we think of laboratory education, microbiology and blood bank clinical rotation sites, where individuals who have gone through a medical laboratory science training program need to have a on-site bench rotation, those are very hard to come by. In a different survey, 55% of university-based MLS programs were having difficulty in finding those microbiology sites. And if you don't have that, the students don't have access to those patient clinical samples, workup protocols, or access to some of these big ticket items that you have in a large laboratory like a MALDI-TOF or a blood culture instrument. And that makes a real difference in their education. So sadly, the go-live of our microbiology core lab had some major and unanticipated impacts to our regional education programs. Because these different Providence laboratories supported various different educational programs in their clinical rotation sites, we went from 7 different opportunities and options where students were rotating down to 1 single site. And there's 10 different, not only our own in-house laboratory, but 10 different regional educational centers shown here that no longer had the opportunity to place students at these locations. So sadly, our clinical education program, particularly our School of MLS, really was not included early enough in the conception and planning phase for us to really start to theorize and come up with an alternative solution, resulting in some pretty permanent changes to the opportunities that these programs had to place students. And that is definitely an unfortunate impact to our regional MLS staffing capacity. So after all of this testing and thinking and planning and evaluating, now we need to start to go live. But that being said, here's some more not data. So one of the highest concerns that we've always had, I think that kept some of us up late into the night thinking about this, is growth failure. You can't prove a negative, and if we had organisms, fastidious organisms, or rare organisms in some of these cultures, if we didn't grow them, would we ever even know about it? And at the end of the day, we don't really have a good answer to that question. But to do our best with what we had to understand and control for that, we did implement some pretty rigorous amounts of quality control measures. So each single culture tote that comes into our laboratory every single day, between 10 and 12 typically, includes the following: the warmers, obviously, the pre-incubated cultures that are in whatever appropriate gas box they might need, packing list to make sure that, the list of what cultures were included, a packing checklist, which is shown here to make sure that each of these items is included and initialed by the staff. And each tote also has its own dedicated thermometer and a freshly plated plate of a QC organism, a fastidious control strain of Haemophilus influenza or Neisseria gonorrhea. And the thought is that if we have the capacity to know and understand what the range of temperatures were happening inside of that tote, and we had evidence that a fastidious organism that was plated not hours before getting into the tote, but right before going in, the box lid being closed, was able to grow, it was pretty good evidence that that tote during that transport and that day was able to support growth, and therefore the other cultures there would likely be do so as well. Won't dwell on this slide, but just to show some of the other work that we put into to make sure we were ready for go live. This is showing our regional core lab SharePoint. Some of the resources we included an issue entry log. So anyone at a spoke site or the core site, if they have an issue with a particular culture, can click on this button and it automatically populates a list of emails that go out to different leadership and populates a issue log that we resolve regularly in a weekly call. You have access to our QC logs, SOPs that are relevant to everyone, and some other resources that we compiled as well. So finally, we felt like everything was ready for our go live. Our project goal was always to have a 3-phased go live of this core lab starting in November of 2021. There's a couple of reasons for this. The first was that we needed to do this because of our LAS functionality and a planned change that predated even this core lab design. So for the phase 1 and 2 sites, that's Northern Washington and Western Washington, we were all at the time using the Cerner LAS system. In the interim, after go live of phases 1 and 2, all of us were required to switch to the Epic Beaker system, which was its own hurdle to overcome. And then finally after that, we would be able to go live with phase 3 with Southeast and Montana sites that were already using the Epic Beaker. So phase 1, again, these are our northern Stevens County rural urgent access hospitals. And we were excited to go do on a smaller basis to really trial out our SOPs, our courier, and the communication process, et cetera. And even that was a little bit different than what we expected. So we planned to start sending pre-plated cultures in November of that year. But what actually happened is that in October, due to some severe staffing issues, they were unable to start sending pre-plated cultures. They just didn't have any techs available to do that work. So they actually had an entire month, and almost literally an exact month, of October, where instead of doing the work in-house, traditional, sending specimens, which is a typical reference or centralized lab model, they would be doing those two approaches instead of, and then eventually switching to pre-plated sending to the core lab with evening shift workup. So what you're seeing in these 3 histograms, with not an awful lot of data, are the hours to the first charted culture result over the course of the day. So in this first one, with this status quo prior to the core lab, you see a really normal biphasic sort of hump where you see the first hours of the day, half the cultures get reported out with about, most of them occurring between 18 and 20 hours. And then those that couldn't be finished, that first day shift, wait for the next day. When they were sending their specimens down to Sacred Heart in the core laboratory, we didn't have very much of anything that was reported at first. Most everything was pushed back even later to that second day of reporting. And we compare both of those to pre-plated cultures that could be looked at during the day shift or evening shift of that first day. And what we see is that under the pre-plated culture approach, almost 70% of those cultures had a first verified result by 24 hours, and 94% of them had the first verified result by 36 hours, which is an improvement over both of the other approaches. And this really made us, this very naturally occurring experiment that we didn't plan, really helped show that under this model, more cultures are being reported with that first charted result within 24 to 36 hours. After we went live with our phase 2, we were able to look back at some of our go live data, not from this rural site, but from a large urban hospital laboratory. So you're seeing similar data. This is a histogram showing the hour of the day, or how many hours until the first charted culture result. If it's a little small, but you can see that most of these were reported again around 18 to 20 hours. And then in the post-consolidation, we see most of them get reported in day 1 with this other shoulder on day 2. What is interesting, though, is that this laboratory had a pre-existing policy of, at around 12 hours, they would go in, open the incubator, and look at each of those plates, and they would report a simple growth or no growth. No workups, no gram stains, unless it was like a specific request on a one-off situation. But essentially, these preliminary culture results were representing a very minimal amount of data. So this shoulder, previously happening at this lab prior to 18 hours, is really represented more with what is pushed back to greater than 24 hours in the second day. But what we feel really confident about is that the material information they were getting, which included a MALDI-TOF result and a susceptibility test already set up, represented more actionable final clinical data compared to what they were seeing, even if the average time to first preliminary result is, as expected, a little bit longer. Finally, after going live with everything, we were able to investigate and look back and compare our idealized model to real-time data. As a reminder, this is a model showing, at those specimens that are arriving into the laboratory between the hours of midnight and 1 a.m., it takes about 30 hours until they can be read. And this dot plot over here on the right is plotting the data of the time received to the spoke lab, to the first charted culture result, charted against the time of day. And as predicted, much to our satisfaction, we're seeing that by and large, most of the culture results fit that exact model, where the laboratory specimens arriving to the spoke site between early hours of the early morning, we're getting that first reported result between the hours of 30 hours, with most of them falling along that same line. But this kind of data also reminds us that this is a very idealized approach. So we did see, particularly with these cultures that were arriving in the late afternoon, took a little bit longer, average of 20 to 28 hours before that first result. So this probably represents some opportunities for optimization within our core laboratory. Could we be touching them faster? Could we be getting our results entered sooner, etc.? And this kind of analysis also helps show that, well, in many cases, it looks like there were samples that maybe did not get included, struck out, and sent that first day. So they sat around in the sending site for an extra day before coming out here to the core laboratory. But what that really helped us feel confident about is not only the clinical performance, but that at least some of the things that we had planned for was occurring as we had hoped. I didn't include it here, but I'll just say anecdotally that when we started to see some of these results really come in addition having our in-house mycobacteria and fungal cultures, some of our clinical individuals who were the most concerned about some of these reports suddenly became, this changeover I should say, suddenly became some of our biggest advocates and were really calling out the big improvements that they were starting to see and the access that they suddenly had compared to what they would have experienced if we had unfortunately had to send everything out to, say, a commercial reference lab. So that brings us to this last point, our final phase and ongoing. And the main thing I wanted to talk about here is something that we really can't always prepare for or plan for, which is the weather. So those mountain passes, again, another thing that we were very concerned about and a thing we really have had to deal with. The inclement weather over Snoqualmie Pass, which is shown here, and the Montana and Idaho mountains as well, they really can disrupt travel and courier routes. Additionally, we had to formally establish flying protocols for the Western Washington sites that were wanting to fly totes. This means that we could not use our lithium battery-based warmers. Those are not allowed per FAA regulations. So we had to validate the use of chemical warmers. They're basically larger versions of like the hand warmers you would have for like football games. We all, because they don't get as warm and they take a little longer to warm up, we had added additional insulation to keep our cultures warm. And then for flying, we needed additional specific materials for packaging in case of violent decompression. And I'll give you an example of a time when everything went wrong, the investigation and the follow-up we did after a failed tote delivery. So during a few years back, a particularly bad winter storm meant that the passes were closed for driving, and so we made the decision to fly. Unfortunately, due to a mishap with handling, so nothing that the laboratories did wrong, a tote that was containing cultures got left behind in a cargo hangar for more than 18 hours before it finally got picked up the next day and delivered. So we were able to rely on and investigate some of our quality control measures. When we opened it up, the tote temperature was around 16 degrees, about 60 degrees Fahrenheit, so definitely colder than room temperature, not ideal. But our QC fastidious organism plate grew successfully. And then when we looked at all the cultures had residual samples that had been left behind at the spoke site. We had all of them reset that there was residual material. And then we did a specific culture by culture evaluation. And in addition to just saying what were the culture types and what grew, we also did a look at how many hours did that culture plate incubate in-house before it even went into the tote at all. And with only one exception, well, there were certainly a few that maybe had less than the ideal 18 hours of culture, but there was really only one culture, a MRSA screening culture, that really was only struck out 1 hour before going into the tote, and it didn't grow. So that's a little bit nerve-wracking. We, of course, couldn't say, we were worried that maybe it didn't grow due to the tote, but the reset also failed to grow. And with this evaluation and our QC metrics, we concluded that there really were no observable impacts other than that delay. So that brings us to where we are now. We're trying to, with the existence of this core lab, the support of our clinical providers who we consult with, trying to tackle more regional and system level quality improvement approaches. I'll be talking about one of those in just a minute in my part 2. We're refining our testing and quality metrics. Can we do anything better about how things are being worked up and reported? We're also really trying to think about education and clinical rotation. You know, there are still active microbiology testing and workups that are quite important at some of these satellite labs, that gram staining, that plate setup, et cetera. So could we do some sort of simulated plate workup approach? Can that serve as an appropriate, or would the programs that need these sites see that as being equivalent to allow their students to get that training? We're trying to do our best to fill that gap. And my dream, pie in the sky dream, is to use our core micro lab with the other system-wide micro labs to develop some kind of microbiology center of excellence priorities and criteria. So I hope what I've shown you here in part 1 is that these pre-plated mobile incubation totes are a viable method for consolidating micro work. It takes an awful lot of work to consolidate a lab, as we showed here, and that consolidation, even when you keep some testing on site, has impacts to that clinical lab training, and that those robust control methods are essential for addressing any logistical challenges we might encounter. So we talked about the solid consolidation. We want to transition into high standard standardization. And for this part, I want to talk about our work in blood culture contamination monitoring. So just as a very brief overview, blood culture contamination is the recovery of a non-pathogenic skin flora organism in a patient's blood culture. This has very major healthcare and laboratory quality impacts. It's an impact to patient, it triggers unnecessary treatments, delays their discharge, major impact to healthcare systems. Higher CLABSI rates, that's a central line associated bloodstream infection, a mandated quality metric that we report, and there's financial penalties for healthcare systems. And also results in very high costs. Big estimates on how you calculate the numbers, but estimates range between $2,000 for every contamination event up to $25,000 per event, and some say it's up closer to like $120,000 for every single false positive. And most of that is due to that extended length of stay. So in Providence, we have this standard goal of 2 to 3% contamination rates, and sadly we didn't always achieve it. But some big changes happened around 2022 in the world of blood culture contamination. First, CLSI, a group that creates a lot of ideal documents overseeing lab testing, finally updated a document about the principles of lab culture, and they maintained that a threshold of 3% blood culture contamination is what to aim for, but that a rate of 1% is possible. Really, the first time they had said, hey, we can get as low as 1%. That seemed unimaginable in 2007 when it was first written. Additionally, the federal government, CMS, listed blood culture contamination as a patient safety measure and something that accredited organizations needed to monitor and report. Finally, within Providence, a number of active trials of so-called diversion devices. I'm showing 2 different models right here, the SteriPath and the Curin. These were proposed as a solution to contamination, but we abandoned them due to high costs of these devices. Essentially, what they do is divert away the skin plug and any flora that is on the skin separately and away from prior to the blood entering the blood culture bottle. Works very well, there's data to document it, but when it costs between $12 and $25 per each device, multiply that out, it's a very costly endeavor. So what are we working on within Providence? Well, in 2023, we made this a system lab and infection prevention quality improvement goal to reduce CLABSIs, save those costs, et cetera. On the infection prevention side, they established some really, really excellent education modules that were rolled out, assigned, didn't really change our numbers. In the lab, the phlebotomy team talked about standardization of a collection kit, so they have everything they need right there. Talked about revisiting trials of a waste tube, basically doing the same thing of the diversion device, getting that first little bit of blood. And then in the microbiology technical work group that I am lucky enough to help support and oversee for Providence, we talked about 2 things. standardizing our blood culture contamination reporting so that our data is accurate and comparative, and also supporting a system blood culture contamination dashboard. I won't go into all of the details that went into that we had to standardize, but the very first thing, and what I will show, is that we needed to standardize our list of what organisms constitute a blood culture contaminant when recovered in one of multiple sets of blood cultures. There's numbers of different sources that provide largely overlapping recommendations for what these organisms can consist of. Everyone includes coagulase negative staphylococcus, Cutibacterium acnes, Corynebacterium species, but then some groups recommend maybe slightly different things, the viridin strep groups, Micrococcus, etc. Over here on the right is what we decided. This is our standard list. There's a few things that don't always appear in everyone's list, Cutibacterium species, courier species, but we felt comfortable. This is, when recovered in one of multiple sets, a reliable list to say this is likely a contaminant. So after a lot of work and labor, we were very thrilled to roll out in 2024 a Providence Standard Blood Culture Contamination Dashboard. If this talk was about bragging, I would probably spend the whole time showing it off and demonstrating it live. It's so cool. It's such a great repository and such a wealth of information. But a few things I do want to point out. This is a auto-populating Epic-based chart report, or rather the metrics are pulled directly from patients' charts, updated every single day. And there's just this vast number of filtering options where we can get a sense of our system-wide contamination rates, filtering down to different regions, different hospitals even different collection departments like the emergency department versus inpatients, and collection workflow. Was this collected by a phlebotomist or by a nurse? Really, really phenomenal power that we never had to really understand, apples to apples, who is being successful in their various initiatives. But more than just this summary report that kind of shows everything, which is accessible to anybody within Providence, but we also helped support a creation of what we call the detail report. And this is not publicly available because it does list out both PHI but also collectors. This report includes this list of the actual individual employees, caregivers, who did the actual collections. We can sort them by, again, those same filters, where they are, where they work, etc., and get a sense of how many collections they had done, how many grew contaminants, etc. So really, again, just a wealth of information was now suddenly available that we never had access to before. So the educational component that the infection preventionists rolled out, very helpful, very worthwhile, did not successfully move the needle. And launching this dashboard, the data alone is essential, but ultimately was not super successful, at least in and of itself. So these efforts do go on. But thanks to this blood culture contamination dashboard, we immediately started to notice a few unexpected findings. So I'm calling this slide Dashboard Confessional, because we found particular collection issues that we never could have anticipated. First, we found that a high frequency and high contamination rates for individuals who were not identified by name, but under generic user or generic nurse. In fact, these were the most common collectors in the Providence healthcare system. So the joke was, if we could find generic user and generic nurse and fire those two, our contamination rates would go way down. But really what this represents is a gap in the data. We don't know who collected these different cultures. We also saw that even when we sort for collection workflow, for example, looking specifically at the phlebotomy collections, we were finding individuals who were identified by job title as nurse appearing in the wrong locations. Meaning, if a phlebotomy supervisor uses this filter, they might accidentally be ignoring a phlebotomist who was misclassified, or a nurse supervisor or ED manager might have a nurse who is contributing to different contaminations, but would not be pulled out in the particular report. So to understand the scope of these possible discrepancies and how we might correct those with workflow adjustments, we're able to recruit members of the Sacred Heart School of Medical Laboratory Science. So I definitely want to shout out these different awesome students for their work. The generic collector work was done by Riley Gray and Stephanie Wang, and the workflow analysis was done by Lindsay Gatton and Gabby Tato, who we've hired in the micro lab. So the data shows a full year worth of data, representing about 500,000 total blood culture collections. And then we again use those different filters in the dashboard to drill down to these two different collections. And I'm not going to walk through this slide, but I do just want to remind the group that when we think about blood cultures, it's very easy to think of it as 3 steps. Clinician orders, someone collects, lab receives. But it's actually quite a lot of steps go into all of this, a lot of clicks and a lot of those things that we know are inherent to ordering. And while we think of all the different things, all these different steps, a lot of the education and the attempts to reduce blood culture contamination, they really focus on the physical collection step. But especially when we're talking about the fidelity of our data and where we know the contaminations are happening, all these other steps are very important as well. Where are the pitfalls? Where are the gaps? And when we really zoomed back and thought, hey, when we see these higher contamination rates in generic users, for example, what that really suggested to us and what we made our hypothesis is that if one part of the collection workflow has gone wrong, like the user documentation, the more clerical components of a blood culture order, it's more likely that another part, meaning the physical collection, has also gone wrong, resulting in contamination. So, some findings that we think support that hypothesis. Finding number one, looking at the overall generic, this is the unidentified collectors, we found that they have higher blood culture contamination rates that are really meaningfully contributing to our system totals. So when we look over this calendar year, our overall Providence contamination rate was 2.58%. When we look at only the contamination rate by these generic unidentified users, their contamination is 5.9%. And so the overall rate with these eliminated or excluded from the analysis is 2.26%. So with that additional 0.32% of blood culture contaminations, those are all being contributed by users who are not identified. And if we could just magically eliminate those, we would have had 1,673 fewer blood culture contamination events during that year across our system. And you can do the math of like per event, how much that potentially could have saved. We did find, or they found, that all of our Providence regions had some amount of this generic collector practice, but not equally distributed. So Northern California and Alaska certainly had the highest proportion of generic unidentified collectors, but Southern California, which is our highest volume, highest collection location, even though their percentage was lower, only about 2.2% of their overall collections were those generic unidentified folks, that still represents 4,736 collections over the course of that year. So it's really a problem that we wanted to understand across all of our Providence locations. So next we wanted to look at this workflow classification. Essentially, laboratorians or phlebotomists who are identified as having collected under a nurse collection workflow, and nurses who are inaccurately identified under the laboratory or phlebotomy collection workflow. So the data you're showing here is when we are only filtering in the lab collection, so ideally only blood collections done by phlebotomists, you can see the total number of cultures in green, and then down here below is the contaminated draws and the contamination rate. So the contamination rate for laboratorians under the lab collection, 1.3%. Blank is somewhat of a gap in that particular area where not all of our cultures populate with phlebotomy or laboratorian job title assignments, but when we see that these blank collectors have about the same contamination rate of 1.5%, we're pretty confident that most of these are likely phlebotomists as well. When we look at those nurses who are under the lab collection workflow, certainly a lot fewer. No doubt that it is not a huge number of our total collections, but when we look at the percentage of contamination, nurses collected under a lab workflow have a 4.6 contamination rate, higher than the overall nurse contamination rate of 2.9%. And then we take this same approach and look at laboratorians for phlebotomists collecting under a nurse workflow, we find the same phenomenon. Even though it's a much smaller proportion, laboratorians collecting under the nurse collection workflow have a higher contamination rate, 2.5%, compared to the overall lab contamination rate of 1.3%. Again, we really feel like this supports our hypothesis that when one part of the process has gone wrong, another part, including like the physical cleansing and necessary physical steps, could have also have gone wrong as well. One last finding that we really thought was quite eye-opening is that, and we think that supports the idea that incorrectly classified workflows stem from specimen management and the upfront processes. Lindsay and Gavi were also able to look at the individual names of collectors who were appearing under the wrong workflows. So we see that pesky generic nurse collector, who is a real problem, but we're trying to do our best to identify it. And they found all of these specific nurses and certified nursing assistants across the system. Not only did they find that these were really not localized to any one location, but what really jumped out is the fact that the three most common nursing-associated individuals, employees, collecting under the wrong workflow, but they're all CNAs, they're all certified nursing assistants. And why is that a problem is because in the three regions where this happened, in Washington and California, CNAs are not allowed or not approved to do blood culture collections unless they have certain licensures and certifications, and I can tell you that these individuals did not have that. So what we think is happening is this very collaborative, helpful environment where one person might be scanning something in, printing out labels, entering information on behalf of somebody else. It's actually meaning that it is masking our ability to drill down and understand who might benefit from additional follow-up, retraining, understanding of what is actually contributing to the blood culture contaminations that they are observing. So I'm not going to walk through all of these with this thought of really taking careful account of the various steps that are associated with and involved in blood culture ordering, the work list they go in, the labels, the actual collecting, etc. What are some steps that different people can take to address these and how we can be a little bit better about this work? I don't have data to support it now, but thanks to this project, various different laboratories, Sister Hospital in St. Patrick's in Missoula, Montana, Southern California laboratories have made significant reductions in the number of generic collections, and likely in combination with other efforts, their blood culture contamination rates are in fact trending downward, which we're very happy to see. So for this part two of the conclusions, we really cannot say enough about just how incredible and powerful this system-wide blood culture contamination dashboard has been for really understanding our blood culture contamination rates. We really feel that having this accurate data, the data coming first, allowed us to understand some unanticipated sources of possible error that are contributing to this very important quality metric. And that blood cultures that are collected with errors in that processing workflows, including the two that I talked about, user identification and collection pathway, are more likely to be contaminated. If that's a universal phenomenon, I would love to hear about it, but this was a very rewarding finding and project to be involved in. These were two very, very large projects. I do want to be sure to acknowledge all of the different individuals. Our Providence system and regional leadership who championed and helped supported the core lab formation and the dashboard creation, our Sacred Heart microbiology team and leadership, the School of Medical Laboratory Science, and those students who did the projects, the leaders at the various regional spoke labs, and our courier team, and then those analysts who helped stand up our dashboard, and the members of what we call our regional clinical steering committee, the infectious disease, infection prevention, and pharmacists who we meet with regularly to understand and improve our core lab service. And with that, I will land on this last slide. I'd be more than happy to take any questions. Thank you very much for your attention and your time today.
I have a question.
Yes.
Can you comment for the first part regarding your consolidation on fungal and AFB cultures?
Yeah, so the question is specifically regarding fungal and AFB cultures. In this aspect, none of the laboratories that were sending us, that converted to sending us all of their culture workup, had existing in-house fungal or AFB capacity. So all of those were send out tests to a commercial reference laboratory. So in that respect, they were able to have a lot more direct oversight, and with our daily single drop-off, there was no risk of a late pickup by a FedEx, a late drop-off, and so it was the fungal cultures in particular that some of the more skeptical infectious disease docs were particularly pleased with. They had lost too many samples, and one particular case where we grew an mycobacteria in a fungal culture, we called up to say, hey, we found this, can you just add a mycobacteria culture order and we can report that result. We could not hear more about it. He was over the moon. He said, we never would have seen this before. I can't believe you're doing it. And suddenly he genuinely is one of our favorite champions because of that exact phenomenon. So that's what was happening and that's what we're doing now. Yes?
I
Thanks for the great talk. So my question is also on the first part. So you mentioned that from the lab consolidation, you observed some issues on the educational programs. So how are you thinking to address those and improve the education of the trainees?
Yeah, it's a great question. So with the different impacts to the educational programs, how are we seeking to address and what to do with that? It's really an ongoing and really multifactorial issue. The clinical training programs everywhere are really having issues. I really highlighted the change that we did not anticipate and unfortunately did see, which is the reduction of that clinical rotation sites. And our director of our clinical education program in the School of Medical Laboratory Science, Lorianne Molinax, who previously was at the University of Washington, she's really been trying to think of additional ways. I kind of mentioned some of like a simulated laboratory experience. Do they have capacity at those sites to take on some of those students? Again, I really focused on the medical laboratory science training. We don't support, we did not have existing residents, fellows, and other folks who had a laboratory component to ours. At the same time that is occurring, that did occur over the last number of years, those general programs have had a lot of other particular issues. One of the challenges that we would need to overcome is not only proposing an alternative to a bench rotation for those students, but for those for those programs, their training of medical laboratory scientists and technologists requires accreditation. So for their ongoing accreditation, would they see those alternatives as being acceptable to what they lost or what they otherwise could have had? In my view, I think that it seems perfectly reasonable. I think you can get a very adequate bulk of microbiology laboratory experience just doing the kind of rapid response laboratory work that did stay behind. But it's ultimately not for us to decide. So unfortunately, I wish I had a more conclusive answer. I think we all wish we had a more conclusive answer to how we're going to get more MLSs and MLTs trained, but we're still trying to work through what the best and acceptable options are going to be. Yes?
My question is also about the first part. Great talk, and sort of actually like along the lines of Dr. Tonsarli's question. What is the staffing model now at those spoke labs? Like, do they still have microbiologist specialists, or did they ever have microbiologist specialists? And who's sort of overseeing, I guess, like the competency of those microbiology tests like gram stain and culture setup, things like that?
Great, yeah. So the question is about what does the staffing, residual staffing look like at some of these spoke sites in terms of microbiology capacity? And I'm really glad you also mentioned what does the competency look like for those sites. Competency was a big thing that we think a lot about and worry about. Each one of the sites that is sending us microbiology work now essentially had a full microbiology lab in-house at the time. So as predicted, when this change did occur, that microbiology expertise at those sites, there has been attrition. There's been retirements, people who have moved over into other laboratory areas, et cetera. But everyone who currently does operate in a supervisory capacity or a lead technologist capacity did at some point work in a microbiology space. There have been a few folks who have been cross-trained as generalist laboratorians who are now doing more microbiology gram stain reading than they would have otherwise probably have done. And there have been a few hiccups. One of the challenges is gram stain reading, for example. It's so simple, it's so cheap, but there are times when it can be really, really challenging. One of the things that we are thinking about trialing, this is an approach that Geisinger Health out in Pennsylvania, which is also a very wide dispersed laboratory, back in the mid 2015, 2017, there's a few little publications on using smartphone adapters on microscopes for a virtual gram stain consultation. So under this model, the sending laboratory still is required to have competency documented, people performing and reporting it, they still are the ones who are ultimately responsible for that result. But for those rare, challenging cases where you're just not sure and you really want to be right, the thought is, and we developed a protocol for this, we haven't rolled it out yet, could they potentially reach out to the core laboratory with our more experienced gram stain readers for a consultation to say, like, yes, based on what you're seeing and what you're saying, I do think that you're right about X, Y, or Z. So that's one way we've tried to think about creative solutions. Again, we haven't rolled that particular one out, but that definitely has been a hurdle to deal with. And I'm glad that even this number of years into this experience, it actually has been we've been able to maintain a lot more efficiency, competency. These gram stain issues largely went away. So it has been a little bit better than I anticipated, but worse than, or not as ideal as if the ideal state is everyone has their own microbiology lab just downstairs.
So with respect to your last idea where you're going to put a camera on your microscope and have somebody look at it remotely, there's some validation requirements that would be involved with that, like telepathology. Are you going to go down that road?
Well, you've hit on exactly why we did a small project to pilot out what it would look like. Again, in this context, our sort of hand-waving approach would be that it is not ultimately the responsibility of the consulting individual who is like offering recommendations or a second opinion on that gram stain. It's ultimately the responsibility of the sending laboratories, and so their own validation and verification approaches to gram stain competency would be required. But you've hit on exactly why I'm hesitant to see this as the ideal solution to a non-ideal problem. Really, the ideal thing is that everyone maintains adequate competency for the gram staining, in-house molecular testing, plating, et cetera. And yes, that's exactly why whenever any sort of change we would think to do like that would need a lot of work and data to support it. Yeah.
Did you consider using trains to move the specimens across the state?
Question was, did we consider using trains? Not a lot of trains go door to door to the individual locations. So when we did look into the courier services, again, we kind of predicated it on what we knew in terms of our geographic location, the sites that were willing to and able to move at first just samples, hospital to hospital. I can't say we specifically ever modeled out if trains were a component of that, but again, it's sort of largely going to be dictated by what courier services are available in your region. Yes?
Can I ask what microbiology consultation looks like with this kind of model with just one of you, but then multiple hospital-based sites, especially as you transitioned into it, if that's improved or?
Yeah, great question. The question was about what does microbiology consultation look like under this larger model. I would say somewhat unusually to what I think a lot of microbiology directorship and leadership looks like. It's very quiet in my office, and I'm actually almost chasing down individuals to do consultation. That's not to say that I don't make my own number available, and in many instances, the standing up what we called, again, the Clinical Microbiology Steering Committee was my attempt to, well, if you're not going to call me, then let's have a meeting where you can at least express anything that might be occurring. So case by case, request by request consultation occurs quite rarely compared to what I would expect. I genuinely hope that does improve in the future. I would like to see more of that. I think that would help support, again, some of that laboratory and clinician collaboration that I think is so productive to actually practicing of laboratory medicine.
We have a bunch of online questions and we probably won't be able to get to all of them, but let's, if we can hit one or two.
Of course.
So one of the questions is about the use of discard tubes for blood culture contamination. I wonder if you can comment on that kind of generally.
Sure. I breezed really quickly through it. If you can bear with me to go back a few slides. Waste, if you look in the literature for waste tube or discard tube, the principle is exactly as what you would see with a diversion device. Essentially, you just take a cheap red top and starting with that during the course of what you're going to drawing a mil or two of blood into that and just throwing it in the garbage. Essentially, it serves the role of just if there was improper cleansing, it does prevent that bacteria and skin plug from getting into the blood. This was trialed out in Alaska, and when it was initially rolled out in Providence, Alaska, we did see a reduction in those initial blood culture contamination rates. We think there was other contributing factors why it wasn't a lasting impact. I do think that is going to be a potential component of a very multi-component solution to blood cultures, but there's definitely a lot of literature support for that approach.
And then I think in the interest of time, we'll skip the other questions.
Okay.
Great, thank you.
Thanks again, and appreciate the invitation. Take care.